Our procedure today will be as follows. I'm going to ask each of the panelists to introduce themselves, to tell you a little bit about where they're from, what their research is on, what their interests are. And after we complete the introductions, I will try to kick things off with a series of questions. General question to start, and then some follow-ups from there. When the panel is complete, we will move to questions from the audience so that you will have an opportunity to engage in the conversation as well. So to begin with, why don't we just start at the end and have our panelists introduce themselves.
Hello, I'm Sam Barendess. I'm a professor of neurobiology and psychiatry and director of the Center for Neurobiology and Psychiatry at the University of California Medical School in San Francisco. I'm trained in psychiatry and know about clinical psychiatry, but also I've spent most of my career working in the laboratory on various aspects of brain function and how genes affect the brain. And I'm here because I'm interested in genetic variations and how they affect brain function in people, and how our understanding of how these genetic variations can lead us to create medications that, under the proper circumstances, can be used to help people with various kinds of emotional distress.
I'm Valerie Hardcastle. I'm professor and head of the Department of Science and Technology Studies here at Virginia Tech. My PhD in training is actually in cognitive science and philosophy. And I think I'm here because my areas of interest really are how psychology, neuroscience, and the various other sciences that make up the cognitive science intersect. And so my area of concern really is on theory building and how we can use data from neuroscience, for example, to help bolster theories in psychology or psychiatry, and vice versa. And so I'm interested in the questions concerning how we use the data that we have to help understand and advance any sort of medical treatments we have for mental illness or other sorts of health problems.
My name is Joe Glenmullen. I'm a psychiatrist. I'm a clinical instructor in psychiatry at Harvard Medical School, also on the staff of the Harvard University Student Health Services and in private practice in Harvard Square. I'm a moderate in the debate on antidepressants. I prescribe them all the time to patients and have had countless patients say how helpful they are. But I was surprised myself in my own practice to see somewhat startling and disturbing side effects in patients. Now feel that patients are not adequately warned about the side effects and long-term risks, aren't adequately educated about alternatives, and ended up writing a couple of books on the subject, which got me very involved. First one was Prozac Backlash. Second one just this year was The Antidepressant Solution. Both books have chapters on the new antidepressants making people suicidal. So that got me very involved in the international movement in the last couple of years that's resulted in the new black box warnings. I testified at the FDA hearing that led to the first initial historic warning. And I'm here because I think that this is a really wonderful thing that you're doing, kind of having a public, open forum to debate these issues and coming at it from both a scientific and a clinical perspective. So I'm very looking forward to a lively debate.
My name is David Kidner. I teach social theory at Nottingham Trent University. I started out my professional life as a chemical engineer designing refinery equipment for British Petroleum, and I got bored with that pretty fast, so I became a psychologist. And then in the last 15 years, I've got somewhat disenchanted by psychology's individualistic approach. And that's led me towards looking at the context, the various contexts of psychology. And at the moment, I'm particularly interested in the assimilation, as I see it, of nature by the technological and economic worlds, which is, I think, the most important tragedy, really, of our era. And believe it or not, I think that is somewhat relevant to what we're going to be talking about today, as I hope to show during the course of this debate.
I'm Javi Morai, and I'm, my original field was philosophy, but I've been doing clinical bioethics for the last many years, and I'm not going to tell you how many. And I am here, I suppose, in part to provide comic relief. But one of the things that I've been particularly interested in over the years is the economic changes in healthcare and in medicine, and the ways in which the economics shape an awful lot of other things that we do. We had major changes that came in mental health care through managed care and HMOs and that sort of thing. We're seeing some other changes right on the future. We're right on the edge of some major changes as well through upcoming financial changes through, for example, high deductible catastrophic insurance is called consumer-defined health plans with health savings accounts, things like that. And I think we can anticipate further changes just about as dramatic as some of the ones that we've seen.
Well, thank you all. It might be worthwhile to begin our discussion with an attempt to set some baseline facts, to get some sense of how widespread the problem of depression is. Is it an epidemic? Is it primarily confined to the Western world? Do we find the problems that we identify with depression as a worldwide phenomenon? Is it increasing? If we could get some sense of where we are actually, what's actually happening out there, it would be probably a good place to start.
Well, one thing I think would be important to sort of throw into the mix of a discussion like that is how the definition of depression has changed over time. So one of the most problematic areas of psychiatry is that all of the psychiatric, quote, conditions, close quote, are subjective conditions. None of them is diagnosable by an objective test. None of them is technically a disease because there are strict criteria in medicine for calling something a disease. You have to be able to have definitive testing that explains either its etiology or its pathophysiology. We don't have that for any psychiatric condition. So for example, in the case of depression, if you looked back to the 1950s, before antidepressants were being heavily marketed in this country, the only people who were called depressed, the only people who were labeled depressed, are people who nowadays would be labeled severely depressed. What has happened is that the entire definition has shifted, and milder forms of depression, quote unquote, have been captured in the diagnostic criteria. That started in the 50s with depression. We saw it really blossom in the 90s with the Prozac type, with the marketing of the Prozac type antidepressants. There's a phrase now called marketing diseases to market drugs. And then you can see historically that the same thing happened to OCD. When the first drug for the treatment of OCD was introduced, it was a very rare condition prior to that. Most general psychiatrists might just see 2 or 3 cases in a lifetime, and suddenly it became an epidemic, and all sorts of people were being labeled with the diagnosis. More recently, many of you probably saw that happen with social phobia. Was once an extremely rare illness. Again, a general psychiatrist might see a handful in a career, and it was sort of morphed into social anxiety and ultimately shyness for the marketing of Paxil. And right now I think we're witnessing that with bipolar disorder. Bipolar II has been invented with the marketing of new anticonvulsants for bipolar, and suddenly you're seeing scores of people given this very serious label, sort of allegedly a mild form of a serious illness. To me, it's like saying I have a small jumbo egg. I don't really think it's appropriate. But anyway, so I just want to throw into the mix in terms of do we have an epidemic or not. These are moving targets. These are subjective conditions. And you have to always look at, well, how are you actually defining it?
I think it's also important to keep in mind, to follow up on that, is that with most psychiatric illnesses or conditions, the problem is you're only diagnosed when you actually seek help. So unlike having a gunshot wound, when it's pretty obvious to the rest of the world with the gaping hole and the skeeting blood, what's happened to you, there's a bit of self-diagnosis involved that would get the patient to the psychiatrist to begin with, or the general health practitioner or whatever, and it's only then that you sort of get kicked into the system. So I think it's a very difficult question to answer because it is so subjective.
If I'm recalling correctly, a neurologist friend of mine, this follows up on the idea of the evolution of diagnoses and criteria, a neurologist friend of mine indicates that in what was called the DSM-2, DSM means Diagnostic and Statistical Manual, and this is for psychiatry and mental health care. This is kind of the listing of conditions and the criteria for ascribing them. And the DSM-2 was a long time ago, and I was told by my neurologist friend that one of the central criteria for identifying a sociopath was 3 or more tattoos. Yeah, I need to get my hands on a DSM-2 and verify this, but it's indicative of the evolution over time, not to mention the evolution in the tattoo industry. And the body art industry. The broader point, though, being that I guess I got to make good on my promise that the economics can, at least indirectly, strongly influence how we conceive of mental illness, given that there are not, as indicated before, the stronger, clearer, crisper criteria that we have, at least for some of the, say, paradigmatically, the infectious diseases. You know, you can get your little microscope out and you see the little bugger right there. You know, bam, and he's dead. You do the antibiotics and bang, he's gone. He's a goner. Okay. Not so easy with mental health care. And in the case of particularly adolescent mental health, quick, teeny, tiny thumbnail history. For many years, adolescents who were acting out were called juvenile delinquents. Nasty, snotty kids, you know, who need discipline. Then, in the early 1980s, for broader health care, the government instituted something called DRGs, diagnosis-related groups. It actually only directly applied to Medicare patients who were hospitalized. But the fundamental change was that instead of paying by the day, by the x-ray, the more you do, the more you get, from a healthcare provider's point of view, they said, we're going to pay you a flat fee for this hospitalization. It'll be a function of what the diagnosis and certain other things are, and bam, the longer the patient is in there, the more stuff you do, too bad, you lose. Because you get that amount, that's it. You just take care of the patient, do it. Totally change the incentives. The important point here is that psychiatry and mental health was not included because you just didn't have any real basis for figuring out what kind of money do you do for a DRG of, you know, schizophrenic flameout. That is not a technical diagnosis, I don't believe. But anyway, so what happened then in the early to mid-1980s is that psychiatric institutions, because they were exempt from the DRGs, and not just government and Medicare, but the broader third-party payers, kind of, you know, quickly came on board with that whole incentive-based, incentive-changed approach to paying for health care. That left mental health care off in a different category. And what two things basically, or one other thing that happened at the time, a very important Supreme Court decision allowed parents to place into inpatient care their adolescents, their children, their youth, okay? And we had a period during which basically what used to be nasty, snotty, undisciplined, juvenile delinquent kid suddenly became, you poor, ill child. You are sick. To be ill, you cannot help yourself. We must help you. And we will do it inpatient, up to the limits of your insurance, whereupon you will be miraculously cured. And this happened, and it was well noted, and it was sort of a sad era, and many psychiatrists were deeply troubled about it, and other people who worked in mental health were deeply troubled because it happened again and again. People, you know, youngsters exhausted their lifetime benefits for mental health care. And so then the pendulum went crashing back the other way, and all of a sudden we have managed care and 1-800 Nurse from Hell, and the psychiatrist has got to tell the most intimate details that he or she does not want to share. These are very private things with some clerk on the phone who may or may not have graduated from high school. And so we had a dramatic shift back the other way in terms of very limited coverage for mental health care. So it's, and the diagnostic ascriptions, whether or not the categories and criteria themselves certainly have morphed along the way.
Well, we seem to be arguing here that depression doesn't exist, or at least it hasn't increased. And I mean, this isn't my area of expertise, but I did read up in the area before doing this debate, and you'll be relieved to hear. And I mean, the studies typically find increases of depression in the last 50 or 60 years are 5 to 10 times often. So we're really going to argue that you know, the efforts of the drug companies to popularize depression and the sort of diagnostic creep involved in successive editions of the DSM account for that entirely. I wouldn't have thought so.
But I think a substantial portion of it, and again, if you look more recently, I think many people in this room will have some familiarity with what happened with social phobia. So social phobia was a really, truly, exceedingly rare condition. The only people who were diagnosed with it were people who would never go to a movie theater because they'd be afraid that in the movie they'd have to go to the bathroom and they wouldn't be able to get out the aisle and they'd be embarrassed, and had extremely limited lives. So Paxil was going to be approved, the first drug ever to be approved for this condition. Well, if you want to market a drug for a condition, you need a much nicer name than social phobia. So for a start, it was changed to social anxiety. And then it morphed into, as I said a little while ago, shyness. And I'm sure many of you have seen the ads for Paxil in magazines that have a little box with 5 or 6 questions. And if you answer yes to 3 out of the 5 or 2 out of the 6, I don't remember exactly what it is, you cut it out and you bring it into the psychiatrist. And I've actually had this experience. And if you read those, it's like, who wouldn't have this diagnosis? Are you uncomfortable in social situations? Does your heart race a little more when you're about to speak in public? You need Paxil. Life is waiting. Life is waiting for you. So, I think if we all have some experience with that very recently. And it's very clear that what was once a rare condition. Oh, and then, what happens is the companies go and pay an epidemiologist to use these new diagnostic criteria to estimate how many people might have it, and suddenly it's literally an epidemic. Literally an epidemic. It went from being a very obscure diagnosis. I'm told it's the leading diagnosis in Japan, the #1 mental health diagnosis in Japan. It's actually a pretty easy thing to do if you have billions of dollars and very sophisticated marketing and research. So I think a large portion of it, yes.
I also think one thing that's happened over the past 20 years or so is we've just gotten less comfortable as a society or a culture with being sad or depressed. And so everyone's going to experience a downtime in their life because they're going to lose a loved one. They're going to experience a severe illness. There's going to be some sort of stress on your life. And it used to be, 25 years ago, that was anticipated and expected. And if you were sad afterwards, that would be interpreted as a normal sort of reaction. And now I think in many cases, when you do have some challenges in your life, no matter what they are, and you end up being sad because of it, that's a shortcut now to the psychiatrist's office in which you get prescribed a drug to help you feel better. So I think what we're taking, and I don't want to make any judgments here, because I do think sometimes people do have very severe reactions to bad events, and they do need help, and I don't want to suggest otherwise. But I think our comfort level with dealing on our own, as it were, with tragic events has gone further and further down. And this, too, has pushed up our diagnoses of depression and anxiety and other sorts of ailments.
It seems to me that the uncomfortable conclusion that I can draw from what I've just been hearing is that as a society, we are manufacturing a culture of mental illness for economic gain. That it's easy to project a situation in which just a little pill will make you better. I mean, we've seen too many television commercials with people dancing through the flowers because they're suddenly happy, but you don't know what illness they had before they were given the pill. All right? And I know that a number of physicians that I've spoken with have said, my patients come in and say, I need to be put on X drug because they saw the TV commercial. And it then raises the whole question of what exactly are we doing to these people, and who ought to be regulating the prescription of drugs for these kinds of ailments? Conditions.
Well,
that's a neutral word.
Yeah, it's a very big problem, and I think that we should not, in all bemoaning the promiscuity of psychiatric drug dispensation, forget that there really are a lot of people who have serious mental illnesses, and that mental illness is a real thing, and that one should not swing the pendulum to the point where one should say...
And these drugs do help.
Absolutely.
And they do help.
Yeah, I think that the criticisms that have been stated by just about everybody on the panel all have some merit. It's certainly true that drug companies that manufacture these medications are corporations that are really only interested in the bottom line, so that the more pills they sell, the better, and they have very, very active marketing departments that think up ways to make more consumers interested in asking for these medications. Legislation has been passed in the past decade that allows for direct-to-consumer advertising, which is something that I think really should be reconsidered, where people are told while watching the Super Bowl that maybe they have social phobia or depression, and that they should ask the doctor. And doctors who are busy and who are frequently working for HMOs and are getting paid very little per visit are all too eager to say, okay, I'll write you the prescription, voila, it's not going to do much harm, et cetera, et cetera. So I think that all these kinds of things that are being mentioned by the panel are true, and indeed the way that medical care is being reimbursed and the way that the medical profession is being run and the way that doctors are being used has enormous problems which weigh on how psychiatric drugs are prescribed, because they're pretty easy to prescribe and they're relatively safe, although Dr. Glenn Mullen will point out that they can cause bad side effects, which they certainly can. But I don't want in the course of this conversation to forget that putting that aside and putting the greed and the marketing of pharmaceutical companies aside, that there is such a thing as significant mental illness, and that it is all too prevalent, even forgetting about the pseudo-epidemics of social phobia and depression that have already been mentioned. Real bad depression is also quite common. Schizophrenia is also quite common. Bipolar disorder, that is manic depression, is also quite common. And I don't want people to come away with the notion that one should just figure that everybody who's got big troubles is just making it up or is a slacker. There are important mental disorders, and there's hopefully a research that will lead to good ways of identifying the bad stuff, the real stuff, if you will, the less, the more severe the extreme cases, and that this in turn will lead to the development of better treatments for people who are really suffering and whose lives are really destroyed by severe mental disorders.
I think that's absolutely true, and I think in terms of a pendulum, it's just trying to counter the pervasive message in our culture in the last decade, largely because of direct-to-consumer advertising, which has driven so much of the sales, not just of antidepressants, but I'm sure you've heard some of the statistics about Vioxx, that 80% of the sales of Vioxx may not have been necessary and were driven by direct-to-consumer advertising, and there was such a substantial risk there. Just to follow up on one of the things you said, I think that the single most important thing that's not done enough in clinical practice is the distinctions between mild, moderate, and severe conditions. And we know, for example, in the case of antidepressants, that 70% of the prescriptions are now written by primary care doctors. We have very good studies showing that they're not happy with that, but it's kind of been foisted on them by managed care. And that on average, they spend 10 to 15 minutes with someone making a diagnosis and writing the first prescription, often with 3, 6, 12 months worth of refills. So that's obviously not optimal circumstances. And I think when you do make those distinctions between mild, moderate, and severe conditions, you can appropriately use medications at the more moderate to severe end of the spectrum, and more appropriately encourage people with mild to moderate conditions to use alternative forms of treatment that have been proven to be more effective, especially over the longer term.
Could you elaborate on that, on alternative forms?
Yeah, sure.
I'll come back to
First of all, my own position is that the drugs, the antidepressants, should only be used in the moderate to severe end of the spectrum, and that what I say to patients is, if you're severely enough depressed to go on an antidepressant, my advice is not to make it the sole form of treatment. These are not really definitive treatments for definitive conditions like an antibiotic is for a specific infection. And so there's usually some other underlying cause, an abusive relationship, substance abuse, all kinds of issues that someone can get other forms of treatment for, and hopefully over time reduce or eliminate their dependence on medication, because one of the more serious problems with the medications is that there are a lot of unknown long-term risks. We don't really know the long-term risks of being on a Prozac-type antidepressant, for example, for 10, 20, 30 years. And we now have a huge cohort of people, which is nothing short of an ongoing human experiment, to have people on central nervous system drugs like this for such a long period of time. The tests for FDA approval are 6 to 8 weeks to get approval for the drugs. So obviously that's not going to tell you anything about what it's like for someone to take for decades. So there are herbal treatments, which I do encourage patients to use for mild, for example, depression. St. John's wort is the #1 prescription antidepressant in Germany. It is not advisable for severe depression. It's not strong enough, it's not potent enough. Exercise, there's a great study of exercise versus Zoloft, which showed that, again, in the moderate to mild end of the spectrum, exercise was as effective as the Zoloft. If you're severely depressed, you usually don't have the energy to exercise, but what I find with people is that if you start them on an antidepressant, you start to do some other form of therapy, over time, as they begin to feel better, they may be able to use aerobic exercise in particular as a strategy for weaning off the medications. For anxiety disorders, the research unequivocally shows that cognitive behavioral treatment is by far the best form of treatment. It's very time limited. Psychiatrists know almost nothing about it. I had to educate myself about it in order to write about it in Prozac Backlash, and I was amazed at how effective it is. And now for a lot of people with OCD, phobias, panic attacks, all the different varieties of anxiety. If your fundamental problem is a relationship issue, there's couples therapy. If your fundamental problem is substance abuse, again, research has shown the 12-step programs are by far the most effective form of treatment for all kinds of substance abuse and addictions generally. So there's really a wide range of treatment options available, but you're not going to get to them in a 10 to 15-minute appointment in primary care. And what happens is someone comes in, the lead case in Prozac Backlash is, I practice in an academic community, so I see a lot of people who move to town, need a new psychiatrist to prescribe a medication that they've been on often for years. So you hear a lot about what's going on in the rest of the world and how people get these diagnoses and how they're treated. So this particular woman had come to Cambridge, was on Zoloft, needed a new psychiatrist. And when I asked her what was going on when she was put on it 5 years earlier, I think is the number, she was tearful and upset in her primary care doctor's office over her boyfriend breaking up with her. So then I said to her, well, what became of that? And she said, oh, he and I got back together a few months later. We're now married. He's here with me in Cambridge. So I said, oh, that's nice. And what about the Zoloft? And she said, well, what about it? And I said, well, you've been on it for 5 years. Did the doctor ever reevaluate your need to it? Oh, I haven't seen him again. Well, how are you on it for 5 years? Well, he gives me 12 refills at a time. That's a year. And at the end of the year, I call his office and talk to the nurse who has him call in a prescription to the pharmacy. So I start to talk to her a little bit about, do you really need this? She's in transition and a new program of study, pretty rigorous. I'm not suggesting that she try going down on the dose now, but I'd like to see her monthly, not once in 5 years, get to know her a little bit. And maybe after one semester is over, we'll talk about whether or not she might want to try going down on the doses. I recall she was on a higher dose. She was on something like 100 or 150 of Zoloft. She wasn't on one of the lower end doses. Comes back to see me the next month, and she was either halfway off or completely off. And I said, why? I thought you were going to stay on this for the semester. And she said, well, I had no idea how much this costs. And I said, well, you've been taking it for 5 years. Yeah, but my own insurance plan had a $5 copayment. I've been paying for it out of pocket here, and it's like $150 a month, and I can't afford that as whatever she was doing at the time. So she went off, she was fine, she's done fine ever since. So, you know, that's the problem that we have.
Segue. Okay, back to the money. Deep throat, follow the money. It is relevant, certainly not solely relevant and not necessarily determinative, but, you know, just I was in the back of the room taking advantage of y'all's wireless online and perusing a few newspapers, and sure enough, a story in today's paper someplace or other talks about how excessively antibiotics are being prescribed for children with sore throat. Duh! And my physician colleagues, of course, get annoyed no end, understandably, by all these parents demanding antibiotics for the child's sore throat. Well, a couple of things there. I'll get to the punchline in a second. Thing number one that I tell my physician colleagues is find out what does the person mean by antibiotics. Example. One of the secretaries who works or used to work on the floor where I have my office was talking to the other secretaries about a trip to the doctor. She had just come back and said, well, I went to see the doctor, and he said, well, it was a viral illness, and he couldn't do anything about it or make it go away sooner, but he did give me these antibiotics for the nausea. Okay, for those of you who are not sure what antibiotics are, they are antibacterial antimicrobials. They are not for nausea, but a lot of people think of the word antibiotics as just generic for medicine. Okay, so that's kind of a side note, but useful to keep track of. At any rate, back to the money thing. This story is paradigmatic of what we're going to see a lot more of, because it's kind of the next thing down the pike that I alluded to in my last set of remarks. One of the things that we have discovered now is that if managed care used to work, it doesn't work very well anymore, partly because it's been largely defanged. The tactics of managed care were, in many cases, intrusive, counterproductive medically and economically. As you play this 1-800-NURSE-FROM-HELL game, we find that sometimes the care plan would not approve things that people needed, would send them through ridiculous pirouettes of bureaucracy to get the simplest thing done, costing a great deal of administrative money along the way. And so most managed care plans are no longer terribly terribly managed. You don't have a lot of this utilization review and so forth. You don't have the narrow lists of providers. You know, you can go to that doctor, but not that one. And to get a referral to a specialist, you have to see your primary care doctor and then walk on your knees over to the phone to get permission from 1-800, you got it. And then yada, yada. Okay, a lot of that is just plain gone. Okay, fine. Now what's to keep the lid on costs? Well, it's called catastrophic insurance with high deductibles. And all of a sudden, and I think on the whole this is a good thing if properly managed, all of a sudden the patient is back into contact with the economics of your healthcare decisions. And the reason I say it's a good thing if properly managed is this. Obviously, we don't want to preclude people who just can't afford the $1,000 deductible, you know, before the catastrophic kicks in, or up to, actually for a family, the maximum out-of-pocket for a year could be up to $10,000. That's a lot of bucks. But we have on the side, and some employers are, for example, helping to fill the health savings account, which is tax-free. Your money, anybody's, your auntie can put money tax-free into the thing. So there's your money for paying your health care expenses. And for most people, the money will roll over, and after a couple of years, it'll be more than the maximum of your deductible. And it keeps building. Okay, very good. But what it means is, all of a sudden, this mom who has the kid with the sore throat, which is probably not bacterial, probably just a viral illness, all of a sudden, instead of demanding antibiotics, maybe she will say, well, you know, the last time we had antibiotics, it actually was pretty costly. It wasn't that bad, but, you know, is there an alternative? Is it safe to watch and wait? Or per your patient's experience, all of a sudden, the patient says, are there alternatives? What's this going to cost me? And you know, without getting into all the pluses and minuses of that kind of economic approach, because that isn't our topic for today, this is going to change things potentially dramatically, because all of a sudden people will understand that healthcare has costs. And whether it's an SSRI, antidepressant, or whatever the kind of medication might be, think, for example, all right, Vioxx and the so-called COX-2 inhibitors were a classic example. If you're insured, it doesn't cost much. If you're not insured, them puppies are expensive. And all of a sudden you're going to say, well, isn't there a generic I can use? Isn't there something over the counter? And so what people expect and want out of their physicians and their healthcare providers is going to change a great deal. Wanting information rather than just a script for something expensive is going to become much more common. One other tiny comment, and that is, as you know, we all started, many of us started out in a fairly critical mode. I think one of the upsides of sort of mainstreaming mental illnesses and mental disorders is the fact that those who do have them are considerably, I hope, less stigmatized. And those who do need hope have a much more open door, societally as well as medically, to go and get the help that they truly do need.
I'd like to clarify something that Joe said, just to clarify, so that it's not misunderstood. There are two things about what he said. First, St. John's wort. I'd like to clarify St. John's wort. Just because something is over the counter and is not being pushed by pernicious pharmaceutical companies doesn't mean that it's good for you. St. John's wort is chemical, it's a medicine, it's actually not controlled as well as it should. And lots of people are probably much better off on prescribed medication than on going to the health food store and buying various unregulated natural products. The whole issue of natural products and their benignity because they have the word natural is something that really has to be rethought. There are lots of natural things out there that are poison, and just because it's natural doesn't mean that one should just take it glibly, etc. And I'm sure Joe would agree with that. The second thing...
We'll get to that.
Okay, good. Okay, the other thing I'd like to clarify is the lady with Zoloft. And I think it's a really interesting case, but I don't want you to forget that she may have been really helped a lot when she got that Zoloft originally. And the fact that she's living happily ever after now, and I have absolutely no idea whether this is the case, might indeed be the consequence of some thoughtful doctor having prescribed a medication and given her some advice, etc., which led her to form that relationship, etc. Now, I absolutely agree that the notion that she can just call up and get the medicine, you know, after 3 months or 6 months or 12 months without the doctor seeing her and get it from the nurses, etc., is really malpractice. And lots of people go on pills like Zoloft or whatever in critical circumstances and can actually get benefit. As far as one can tell, it's really hard to study these things, and we can get into the issue of how one figures out when to use something and how to figure out the efficacy, etc. These are really daunting problems. But I wouldn't want you to come away with the notion that everybody who gets these medicines is getting them for no good reason, and that everything would have worked out just fine if they didn't get them. And I'm sure Joe wasn't trying to say that.
And I think it's important to follow up on that, to keep in mind that we really don't know, I mean, in some sense, very much about depression and anxiety. And so what might work for one person will not work for another person. I think this is part of the problem, because humans love anecdotes. We're not big on data. And unfortunately, the plural of anecdote is not data. So even if you know 2 people who've been helped by an antidepressant drug, that does not mean that if you find yourself being depressed that you're going to be helped by an antidepressant drug. But our tendency to say is, I want what he has because I saw it work for that person. And for the people it does work for, it works quite well. And so you can have genuine tales of apparent miraculous cures by these sorts of drugs. But I think the reality is, for most people, this is not the experience. And for most people, there does need to have some sort of cognitive, social component embedded in the treatment in order to find relief. Or time. Time is a great one, too.
This is really an important point. I have the privilege, being a professor and getting a salary from the University of California and not being dependent on fees for service for whatever clinical practice I do, to practice what I consider is really good psychiatry. I've got the time, I'm willing to see people, etc. Unfortunately, and so I think I can do a better job because I'm interested and I have high personal standards and I'm not just running around with patients calling me every 15 minutes, etc. It's very hard to practice good medicine of any kind, be it psychiatry or general medicine or even surgery, where the procedure is very time limited because post-op care is frequently just a disaster. It's really hard to practice good medicine. And so integrated in this whole issue of the promiscuous use of psychiatric drugs is the whole terrible problem of delivering excellent medical care as we learn more and more about what excellent medical care is to a huge population that craves excellent medical care. And I think that problem is kind of in the background of the issues that we're discussing today. It turns out that it's convenient and easy to just throw pills at people. And as Javi said, it can be antibiotics, it can be Prilosec, or that is various antacids, or which is a huge that is proton pump inhibitors for gastrointestinal problems. There are all kinds of promiscuous prescriptions that are being thrown at people because doctors, the way that the medical profession is set up now, really are not spending enough time taking care of their patients, and that's not only true in psychiatry. So I mean, we have a real problem, but one shouldn't just blame it on the greedy pharmaceutical companies and on the bad psychiatric drugs. This is a generic problem in medicine as a whole.
David's been trying to get in.
Thanks, yeah. I just want to try and put this discussion in some sort of historical context, because I think what we're witnessing, among other things here, is a sort of mechanization and objectification of human being that's been going on for centuries. For example, in 1628, Harvey came up with the idea that the heart was a pump which circulated the blood around the body. In his words, it was, as he put it, a piece of machinery. Now, that's just one example of this sort of creeping mechanization of selfhood that's been going on for a very long time, as I say. And I think the use of Prozac needs to be put into that sort of context, because I think what's in danger of happening here is that subjectivity is something that you kind of tinker with in various ways that becomes the domain of specialists instead of something that you yourself have responsibility for. And I see that as really shrinking the realm of subjectivity because it's being taken over by the specialists. In other words, I'm feeling depressed, so my serotonin levels must be low, so I need to pop a few pills or something like that. So in a sense, the objective realm of science is increasing in magnitude while subjectivity is diminishing. And I would see that as a problem, because the end result is that given enough time, we're going to end up as some sort of cyborg.
Actually, I'd like to follow up on that and kind of tie it into the whole, what you were saying about St. John's wort, because unfortunately, particularly in psychiatry, there's a lot of pseudoscience. So what looks scientific and what looks subjective, like serotonin deficiencies, for example, is actually pseudoscience. The equivalent of the FDA in foreign countries have banned pharmaceutical companies and doctors from promoting these drugs as correcting serotonin imbalances, because that's never been proven, which is really a surprise to a lot of patients who were told that pretty explicitly. And you were saying that you thought it was better not to have patients taking something that didn't require a prescription, like St. John's wort. I actually do feel differently. I think that any time a patient can take personal initiative and do something that makes them feel like they are more the agent, whether it be exercise or going and buying St. John's wort or doing the hard work of psychotherapy or a 12-step program, that is better for them. There are a lot of countries in Europe where you do not need a prescription for an antidepressant. You go in and get it from the pharmacist. And David Healy, who's one of the leading psychiatrists in Europe, has actually argued that that would help to correct some of the more problematic power issues in antidepressants in this country if you didn't require a prescription. I don't necessarily agree with that, but I think it's an interesting debate, and the whole issue of personal efficacy, empowerment, or lack thereof. And just to fill you in a little bit more on pseudoscience, because I don't want to use that word and kind of leave you wondering what does it mean, or have I used it glibly. If you take 100 people, this is now the studies that the pharmaceutical companies themselves do on antidepressants. If you take 100 people who respond to an antidepressant in one of their studies, 85 of them respond to the placebo in their studies. That's only a 15% difference. What's more, the placebos that the companies use they're inert placebos. They have absolutely no physiological effect. To try and translate it into plain English, I call them placebos without side effects. It turns out that there are available placebos with side effects. And these are actual drugs that would not cross the blood-brain barrier, therefore cannot have any central nervous system genuine effect on depression, but would, for example, give someone an upset stomach. If you use a placebo with side effects, that 15% difference disappears. You can study the studies. The double-blind placebo-controlled design is supposed to be paramount to good medical science. You can't really use it in psychiatry if you're going to use placebos that are totally inert. So if you study the studies, if you have a second study going on where people go in and ask the patients in the studies and the raters in the studies, the people who are actually dispensing the medications or the placebos and doing the ratings of how depressed people are, if you ask them who's on medication and who's not, with 90% accuracy they can tell you. Why? Because of who's getting side effects and who's not. So obviously that's a lot of pseudoscience. When we look at the antidepressants and we say, oh, but they're scientifically proven to work, it's much more complicated than that. It turns out that similar studies, same designs, have been used for St. John's wort, and particularly when you're careful to pick a patient population that's only mildly to moderately depressed, they are as effective as the prescription antidepressants. That's not true if you pick a cohort of severely depressed people. But most of the studies done on the drugs are not done with severely depressed people. Suicidal people are excluded from the studies. The more severe end of the spectrum is normally not tested. And last but not least is the issue of children and adolescents. So I'm sure many of you are aware of the incredible controversy in the last couple of years over children and adolescents being the largest growing market for antidepressants, especially at the same point in time in which the FDA has issued a black box warning that particularly in this patient population, there's unequivocal evidence that the drugs double the risk of suicidal behavior. So part of the issue internationally was the debate between risks and benefits. And in children, you cannot show that the drugs work. The only one that's approved for depression in children is Prozac. It's on the basis of just a couple of studies that have all sorts of problems with them. But if you look at overall all the drugs, children and adolescents, they don't work. They're no more effective than placebo, even using the inert placebos with no side effects. Why? Because children and adolescents are more vulnerable to the placebo effect. They're more trusting of authority. They're more likely to feel, if given a placebo, that it's a real pill and it's going to have an effect. Now, having said all that, and the importance of not relying just on anecdotes, and back 15 years ago when the suicidal issue first arose with Prozac, and you had lots of people saying, gee, this made me suicidal or violent, and the companies did retrospective analyses of their databases, which were no way to look at this, and claimed that the drugs didn't cause this. We now know differently. The big criticism was, well, these are just anecdotes. Okay, now fast forward to 2005, we have the black box warning for children and adolescents that they can become suicidal on the drugs. We have the large body of research showing that they don't really work. That's why the British virtually banned them for children and adolescents. You have a lot of psychiatrists in this country saying, but I've seen them work in kids. Well, that's really talking out of both sides of your mouth. That's an anecdote. So, there's just all kinds of issues behind the labels and behind the words that it's, you know, the average person, even the average psychiatrist, doesn't know if you don't really try to delve into it.
And I think this is a very important point because we have an ailment or a condition for which we have now the following treatments: exercise, time, cognitive therapy, and pills. And they all help to about the same degree, which, you know, on the one hand is not very much, but on the other hand is probably better than nothing. And it seems to me when you have this sort of variety of treatments with the same results, this tells us we actually don't know very much about what it is we're treating. And I think that's part of the problem. We can point to the symptoms. We can point to the difficulty it causes in people's lives. We're starting to do research and understanding the connection between the brain and the subjectivity, as was mentioned. But we really don't know that much about the connection between exercise, time, sleep, cognitive therapy, St. John's wort, and Prozac with respect to changing moods.
Well, I think that's true. I think we really don't know very much about how it all works. I think that's really true. But I'd like to clarify a couple of things that were said just so that you don't go away with a completely one-sided impression. First, as far as St. John's wort, I mean, you can't criticize the placebo-controlled studies of the pharmaceutical companies' products and then say that the placebo-controlled studies with St. John's worts proves that it works.
No, I mean, just said they're comparable.
Well, okay, but then you see, there was an act passed in, I think around in the early 90s, which said that all natural products were not regulated by the FDA. This was an act of Congress. And that meant that things like, you know, all kinds of things, DHEA, I mean, all kinds of stuff could be bought over the counter, et cetera. I personally have a lot of sympathy with the notion that people could go into a store and, you know, make their informed choice about, you know, what they might do. But we've already heard that even people who spend their careers trying to figure out what they should do are having troubles figuring it out. So you can't expect Joe Sixpack to go into the store and make the most profoundly correct decision. As far as St. John's wort is concerned, though, just that specifically, St. John's wort has within it, you know, a real drug, hypericum, and it does all kinds of things to the body. I think it may do some good things to the body, which may actually be antidepressant. There's reason to believe that that's so. But it does things to enzymes that metabolize other drugs. It does things to the brain. It's not just some kind of thing that, you know, is like eating carrots. It's you know, that is, it's just because it grows it on trees or in plants doesn't mean that it's cool. And there have actually been very serious problems that have resulted from people trying to kill themselves with St. John's wort or have other unintended consequences. One famous one is the following. For those of you who take birth control pills and the hormones that are contained in birth control pills are metabolized by certain enzymes in the liver. St. John's wort and some of its active ingredients really induce, because it's a toxic substance, the liver tries to develop enzymes that destroy it. And these same enzymes destroy the active ingredients in birth control pills. And so there have been a number of cases reported of people who take birth control pills who get pregnant. And the reason they get pregnant is because the birth control pill isn't working anymore. And the reason the birth control pill isn't working anymore is because this person made the innocuous decision to go to the health food store and buy some St. John's wort for whatever reason. And that revved up the enzymes in their liver that destroy the birth control pill. And so voila, a rather grave unintended consequence of buying this natural product. So without trying to alarm anybody in the audience who takes St. John's wort, God bless you, you know, just saying, you know, people can go to the store and buy whatever they want and make their own informed decisions because they're empowered, intelligent, free people sounds like a good slogan, but one really needs to recognize that if the stuff in the health food stores has any pharmacological effect, it's going to have the same potential problems that other prescribed medications have. Now, to continue, as far as the studies of antidepressant drugs are concerned, I don't think that this is the right forum to argue about placebo-controlled studies, active controls, and the history of the evaluation of psychopharmaceutical agents. Very, very important problem. And I think the issues that Joe raised are all legitimate, fair, etc. It's really, really, really hard to prove that any medical procedure works. And this isn't only true in psychiatry. There have been studies of arthroscopic surgery, for example, where people, you know, they did a placebo-controlled study. Arthroscopic surgery for, you know, because you've got kind of a wobbly knee and it's not working very well. So a study was done as follows. Some people had arthroscopic surgery and some people just had an incision over their knee, and the surgeon didn't do a damn thing to go in and deal with the various menisci, etc. And the outcome was essentially indistinguishable. So picking patients, selecting criteria for intervention, defining the interventions, etc. These are all really, really, really hard things to do, especially for conditions where we don't understand the etiology. The plague of psychiatry is that we don't really know why people develop obsessive-compulsive disorder, or agoraphobia, or schizophrenia, or bipolar disorder. We have some ideas about it. And until we really understand why this happens, our ability to treat with medications, in analogy with, as Javi said, taking an antibiotic and killing the bug that causes it, won't exist. We're at the level of empirical studies and trying to do the best we can, which invites tremendous abuse, but should not just be dismissed as, oh, just go to your store and pick up whatever you want and forget about the doctors. Because despite the problems with the medical profession, there are some of us who are really trying to do a good job.
You know, it strikes me that everything you said is probably correct. You know, medicine is not a science. There are a lot of things that we don't.
Some aspects of medicine.
See, I think it's...
I just got out of the hospital. Trust me, it's not a science. But the thing that disturbs me is, yes, we don't know what causes this mental condition and that mental condition, and it varies from individual to individual. We can go from mild to severe. All that's fine. What we're doing, however, and maybe I'm just totally off base on this, is that following up on something that David introduced, is that we are creating in our populations the expectation that there is a technological fix, that there is a pill that you can take that'll take care of the problem. And in so doing, we're not thinking about the set of expectations we're building into young people, and then as they mature, what they're going to expect and demand.
I think one point that Joe made apropos of that is really very important. The deception about, well, this pill fixes something where we understand the deficiency.
I mean, millions.
That's really unconscionable and misleading, and is used by the drug companies in their direct-to-consumer advertising. And it really should be forbidden.
And millions of patients in this country have been told when they got the prescription, you have a genetically determined biochemical imbalance. You have a serotonin deficiency.
Right.
This drug will top up your serotonin.
That's right.
And is the cure.
And it's not true.
And it's not true.
Right.
And it's pretty extraordinary. You can still see ads on TV
Absolutely.
for these drugs that says that. If you slow the ad down and write it all down, you'll see that it says your serotonin may be low in depression. And it's the legal department that inserted that word.
Yes.
Because there's no foundation for making that statement. And FDAs in other countries have banned it. So I just want to make a couple points. First of all, I wasn't advocating that people just go out willy-nilly and buy whatever they think might help. I think it's very helpful for people to get input from people whose specialty is seeing someone with whatever they're trying to struggle with. But I think that inherent in that is already a power dynamic that shifts a lot of the power to the doctor, the treater, and anything that can help shift the power and efficacy back is helpful. I don't disagree with you that in the case of, for example, the herbal products, some of them are pretty heavily marketed. Some of them definitely have problematic issues. I saw a patient once who, you're supposed to take St. John's wort 3 times a day. And it's very important to space the dose out, but it's kind of a pain in the neck. So I saw someone once who came in for a consultation. They'd gotten terribly sunburned, severely sunburned on St. John's wort, and it turned out the problem was they were taking all the dose at once in the morning. So it's very important to get the input that's available. And just to make clear that I'm not anti-drug. I don't think that all prescriptions for these drugs are ridiculous and pharmaceutical company driven. Let's talk a little bit about the circumstances under which it's appropriate and how one might evaluate that and how you might have the medications be part of what I call comprehensive treatment for whatever the condition is. So for example, in severe depression, there's a whole set of physical symptoms of depression that the more of them you have and the worse they are, the worse your depression is. So people with severe depression tend to have a sleep disorder. Most commonly, they're having trouble falling asleep, but in other instances, it's the exact opposite. They're sleeping 18 hours a day and can't get out of bed. More commonly, they're not eating and losing weight, but again, you'll see patients who are oversleeping, overeating, and gaining weight. They're crying a lot. They can't concentrate. They can't get their work done, can't get out of bed and motivate themselves, maybe suicidal. If a patient comes in to see me and they're depressed, and they have that full complement of serious, what we call vegetative or physical symptoms of depression, and especially, and it's usually a corollary of that, they're having difficulty functioning. And I'm worried with them that they're at risk to lose their job, their livelihood, their ability to support their family, or have to drop out of a degree program. That's severe depression. Under those circumstances, I would recommend to someone that they go on an antidepressant. Why? Because that's probably going to jumpstart them out of this situation, which we clearly would like to do as much as possible if they're getting at risk for hospitalization or losses in their life. But I'm going to recommend that in addition to that, they're going to do psychotherapy or cognitive behavioral treatment or a 12-step program or couples therapy or whatever would address the more underlying causes. And it may be 3 treatment modalities. It may be medications, a 12-step program, and some supportive psychotherapy while they're getting sobriety under their belt. And then, only then would you move into more exploratory dynamic psychotherapy. So there are definitely circumstances in which these drugs are very appropriate. But again, I don't tell people they've got a serotonin deficiency and that we're correcting that. I don't recommend to people that they take these for life. I'm more explaining to them that most of these drugs are stimulants that will lift people's energy and mood and focus their concentration. They're not just used for depression. They're used for all sorts of anxiety disorders, substance abuse, hair pulling, nail biting, obsessions, pain syndromes, headaches. They're kind of all-purpose, feel-better medications. They are not specific to depression. We don't understand, as Sam said, what depression even is. So you can frame taking medications in a completely different way from saying you have a biochemical, genetically determined imbalance that makes you dependent on me as a physician and the pharmaceutical company that manufactures this drug, just like a diabetic is dependent on insulin. Many people are told that. It's completely untrue. You can frame taking the drugs as what I just said, as an energizer that's going to help jumpstart someone out of depression as part of a larger package of treatment that they have a lot of personal efficacy and power and control over, and hopefully nothing's absolute in medicine, over the longer haul, a year or 2, with that kind of effort, maybe they could reduce or eliminate their dependence on medication.
David?
I'd like to suggest that one of the reasons we don't know very much about depression is because we've been looking in the wrong places, and most of the research money goes on neurochemistry and genetic studies. And I'm not suggesting for a moment that's not a very important part of the story, but it's not the whole story. And the evidence is out there that depression is associated with things like income inequality. If you look at, there was one study in Illinois which showed that county by county, those counties with the greatest income inequality had the highest prevalence of depression. Things like lack of spiritual belief, breakdown in community and so on. There's a whole host of social factors out there. And the reason they're not emphasized, or they don't get the grant money, I think, is because it doesn't make money for anybody to point this out. Not only that, it leads to some very politically awkward questions. So I think that needs looking at, and we need to take that sort of thing seriously.
Well, you mentioned religious factors as playing into this. And it's been a question in the back of my mind. From what I understand, you're suggesting to me that however it's induced, whether it's deliberate suggestion or something actually taking place in the population, that depression is on the increase in some form or other. And is there any kind of correlation between that and the breakdown in religious infrastructure, religious belief that we see, especially in Europe, and despite rhetoric to the contrary, I would propose also in this country? There's nothing to step in other than take a pill.
It's hard to know. I mean, certainly in the 19th century, when religion was prevalent, some of the really famous people that one reads biographies of, who happen to have been very accomplished, like Charles Darwin or Francis Galton or William James, all suffered terribly from depression. These were people of high social standing, high economics, born in religious societies, with intact families, etc. And they had recurrent, severe depressions. So just, that is having money and having a family and having a good society and having a high place in society, etc., and being religious, or at least being in a tradition of religion, does not spare one from melancholy. Whether real depression is becoming more prevalent in our society is really it's very hard to know, because of the issues of diagnostic criteria, which have already been mentioned. But there were classic stories of Puritanism being highly associated with depression. Guilt, shame,
Right.
self-abnegation, etc. And so I think that, I know this is Virginia, a red state, but I wish that I could say that religion would solve all these problems, and I'm very much in favor of religion, but I don't think that it's a panacea.
We just elected a Democratic governor.
I know. I was pleased to see that. Yes.
Record
Go Kane.
And you're in an academic community in a red state, so.
I know. I knew that I was not going to be stoned. Had I feared that, I would have kept my mouth shut.
One thing we do know is simply that watching television makes people depressed. The studies are out there that, first of all, advertising lowers people's sense of security, lowers their satisfaction with life. There are studies out there showing if you watch a program like Charlie's Angels, for example, among men, that reduces your satisfaction with your existing relationship and the perceived attractiveness of your partner. Among women, it lowers their self-esteem, and that's just representative television. So, as I say, you really don't have to look all that hard to find some likely candidates.
But that's not depression, there's a difference between that and depression. I think it's important to distinguish those. Yes, I think the study that you mentioned is, I'm aware of that study. These are the happiness studies of, that is where you ask people how they, yes, and I think that the data support exactly what you said. In fact, I think that study may have just exactly been done with Charlie's Angels or some other titillating show. But that's not depression.
Well, I agree. It's the tip of a spectrum, isn't it? Mixing my metaphors a bit there, but you see what I mean. But there are also other studies showing that the average satisfaction with one's life and with one's job has been going down now for several decades. In 1972, for example, 35% of Americans declared themselves to be very happy. In 1994, the figure was down to about 29%. That's a pretty significant drop. So there are factors which seem to be, however vaguely associated with depression, which would indicate there may be something in this idea that depression is increasing.
Well, and you and I wouldn't call that depression because we're in favor of using more, strict criteria. But I think in real life, for a lot of patients going into the office, it does get pretty blurred. You know, to go back to that patient that I was talking about earlier, you know, having treated her over a period of time and having done a pretty in-depth initial evaluation of the woman who I told about whose boyfriend had broken up with her. I mean, I really don't think that she was clinically depressed at the time. I don't think she benefited from the Zoloft. I think she needlessly had side effects and whatever other risks. So you know, and I'm sure there's many people in the audience that feel that they went in and told a primary care doctor or an OBGYN, gee, life is a little overwhelming, and before they knew it, they were facing a prescription. So again, you and I wouldn't agree that that's depression, but how does a patient sitting in the office whose doctor's telling them that it is and giving them a prescription deal with that?
I think that's a very fair point, yeah.
The medical profession's getting beat up a little bit here. Physicians, for whatever reasons, HMO participation, seem to have less time for their patients. They have less time to keep themselves abreast of developments. And so is the idea that we can single them out as the bad guys in all of this, or is there something to be done? I think we need some recommendations on how to take the next step, because we are aware, as you've made abundantly clear, that there are negative effects of some of the medications we're using, some of the treatments we're using, but it's not enough just to say things are bad. Where do we go from here?
Well, I, for one, don't think the physicians are the bad guys, and I'd like to say that as a physician. I think that if you look specifically at the topic of the day, the antidepressants of the 1990s, I argue that there was kind of a convergence of two very powerful social, cultural forces. One was pharmaceutical company advertising and marketing, which is unbelievably sophisticated and has a pervasive influence on medicine. And secondly was managed care, which has also come up a number of times today. So managed care was really just coming of its own in the late 80s and early 90s when these drugs hit the market. And for managed care, Prozac was the quick fix that looked like it would save you money rather than pay for 6 months of short-term psychotherapy. You know, the pill that was, you know, a couple bucks a pill looked like a bargain. Turns out that's not true. If you put someone on Zoloft for 5 years and all they would have needed was, you know, 6 sessions of a little bit of supportive psychotherapy. And as Javi said earlier, the economics got quite skewed. But back then, it was this kind of confluence. And I think you're right, the doctors were caught in the middle, and that a lot of the autonomy of physicians and a lot of the independence and ability to steer medical health care was taken out of their hands. And certainly in the area of mental health in particular, there's great studies, as I said earlier, that the primary care doctors are not happy with all the prescribing of mental health drugs that they have to do, but it's just the reality of our modern day life.
I'd like to say something about personal responsibility, but I think that the place that I'd like to emphasize it is at the level of the individual physician. I mean, I think that if there's been a moral erosion in this country or in this world, I think there's been a moral erosion in the sense of purpose and, you know, and integrity of the individual physician. Not that individual physicians are any more corrupt than any of the rest of us in this audience, but I think that there has been a gradual moral erosion. There's been a sense that you know, you do what you gotta, you do your job, you fulfill yourself, you self-actualize yourself. You're less dedicated and devoted to being virtuous and doing the right thing. And I think we're seeing the consequence of that in the whole society. And why should doctors be any different? I think doctors of old, you know, had, and well, I may just be nostalgic, but I think there was a lot more sense of, you know, I'm a doctor, I've got to do the right thing, et cetera, et cetera. It wasn't sitting there with your computer and figuring out, you know, what the easiest way to make a buck was. Which I think characterizes our society overall. Our society has so hypervalued income and glamour and glitz, et cetera, that doctors are just no different than anybody else.
And I think that's actually very important, because I would urge personal responsibility on the part of individual people. I mean, there is Joe mentioned, there is the expectation that if you're feeling a bit of malaise, the proper thing to do is to go see your doctor and ask for medication, Well, we have a responsibility as people who work in professionals in and around this area to educate the public and to help them understand that that's just not the way the world works. That's maybe what you want, but this is what you're going to get. And I think we need to help the general population first, on the one hand, understand what they can and cannot control. I mean, certainly issues of income inequity may be beyond the control of many individuals, but other issues may very well be within their purview. How much do you exercise? How much are you overeating? How much are you sleeping each night? And if you can sort of get those more in line, I think we will see an increase in satisfaction, which I think is what a lot of people are going to see physicians about. It's not the severe depression, which I do think requires specialized care, but it's this general discontentment, which I think is very much within the control of the individual consumer. Just they don't exercise that control.
Well, and just building on that, my advice to people is be an educated consumer. Don't assume that everything you read in an advertisement or even the newspaper or that you see on TV or even that your doctor is able to tell you is the full story, all that you should know, everything that you should consider in making these kinds of choices. Be informed consumers. My own vision of medicine is a little different than Sam's. I think that by and large, people who choose to go into healthcare are sort of more people who like to help other people. They want to do good. I think if you compare it with some other sectors of life, other career paths that one can take. And I think doctors nowadays are really genuinely struggling to do what they would like to do on behalf of people. Healthcare has kind of become, a war zone. And I remember reading a statistic that the CEO of Blue Cross Blue Shield in Massachusetts was making something like $2 million a year. And if I wrote a prescription for a patient for 45 days, Blue Cross would bump it back and say, nope, we'll only dispense a month at a time. And I think that's where the $2 million is coming from, everybody's extra 2 weeks of pills or whatever. So medicine, no, seriously, so medicine, it's very unfortunate, and I hope that Javi's right, that we might get back to something more sane and equitable and reasonable for all of us. But my personal vision I do a lot of clinical work, and I rub shoulders with a lot of primary care people as well as mental health people, and I think doctors really are under siege and really trying to do the best they can.
I agree with that. I don't think that I certainly know medical students well, and people come into medicine today as they did in my time as a medical student, full of hope, full of conviction, full of idealism, etc. It's the culture and the system that is less supportive of those things, or that waves various temptations in front of them. And I don't have a remedy. I just think that one needs to recognize that as part of this whole discussion is the integrity of the individual physician, and to the extent that people can steel themselves to the temptations that are around them and accept more responsibility as individual practitioners, that's to the good of the society and the patient.
Yeah, dovetailing with all of the above and echoing it, I think that the financial structures we have seen in the recent past have really disabled, in many ways, people from exercising, or discouraged, at best, people from being personally responsible, for the following reasons. It has been thought, well, gosh, we really want to have first dollar coverage for health care because you don't want somebody to have to worry about money when you're sick. There, dear, don't you worry about the money. You just get well, honey, and we'll worry about the money. Now, when we do that, what happens is he loses all control completely. Why? Because he is not going to be allowed to generate costs for moi, I'm the employer, or I'm the insurance company. I cannot let him and his doctor sitting next just decide whatever they want to do, generate unlimited costs for me. What am I going to do? I've got two choices. Controls, I will dictate, thou shalt not spend more than 30 days on meds without my say-so. That's the utilization review. Or I put the doctor under horrendous conflict of interest incentives. Capitation. I say, guess what, doctor? We're going to give you X amount per month per patient, and you do what you want, honey, because if you do too much, it's out of your pocket, not mine. Okay, have fun with your patient. Take good care. Bye. See y'all next year. Now, What that means is, therefore, the patient becomes essentially emasculated, you know, in the gender-neutral sense. The patient has no control because the only control he has is to rack up costs for somebody else. When the patient now comes into control and, yes, responsibility for at least a limited range of the finances, and let me step to the side for a moment and say that let us hypothesize that we have, let's say, about a $3,000 deductible or $2,000, something like that. The vast majority of people will have complete control of their health care. The vast majority of the money is on the other side for the relatively few patients who have serious illness and injury and so forth, okay? The great majority of people will have complete control over their health care, and they can deal doctor to patient straight on and say, all right, let's balance the various things. What are the side effects? What's the effectiveness? What's the cost? What are the alternatives? And it's out of my HSA, which again can be filled by my employer as much as by myself, but all of a sudden I'm rewarded for thinking twice about, is this really worth it, and is there a better way to do this? And so I think we really have seen a stripping of personal responsibility in healthcare that is unnatural. Now, there are going to be downsides. Obviously, people who don't have money, that's a problem, and that becomes a barrier to care. Though I will add, one of the things that has been carved out for this whole approach is preventive services don't come out of your pocket, or they don't have to. They can come out straight from your catastrophic, because you don't want to discourage people from getting preventive care. Be that as it may, and again, that's a whole different topic for a different time. I think we will look forward to seeing greater personal responsibility, and I think you will have very different conversations about healthcare between physicians and patients. The other thing that I wanted to just sort of wrap up with, we have noted that research is sparse, and also it's been noted that research is difficult in this area, very difficult. Actually, Sam mentioned the study regarding osteoarthritis of the knee and the arthroscopic surgery, which had been thought to be fabulous. Billions of dollars every year have been spent on this, and they did an honest-to-goodness, bona fide, almost double-blind, placebo, a sham surgery, meaning placebo-controlled trial. Some friends of mine were involved in that. They had more darn fun designing this trial because, for the person who was getting just the sham surgery and only got a couple of nicks, just superficial, no invasion of the knee, well, these folks are sedated, but they can still be conscious. So in order to make sure that each person believed, I actually got the surgery, you still got something going on in the video, but of course they'd have a video of somebody else's surgery that the patient was watching, and off in the corner the nurse would be splooshing water in a bucket to get the right sound effects. I mean, bang, 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 whatever was required, by golly, they did it, and most people were properly deceived. They knew ahead of time that they might be deceived, so that was the ethics side. But in the case of psychiatry, not only, and mental disorders, not only do you have the difficulties of lacking crisp, clean criteria for diagnosis and ascribing the illness, but think even about talk therapy. Talk therapy is an interaction between a couple of people. It isn't necessarily, let's say if it doesn't work for me, it might not be that kind of therapy is no good. It might just be our interpersonal chemistry, and I just don't like the way he combs his hair, or he doesn't like the way I comb my hair. It's like endless numbers of things can disturb the really kind of gold standard science when you're looking at mental health care and disorders of the psychiatric type.
If I can just pick up on that vis-a-vis the issue of double-blind placebo-controlled studies. One can certainly criticize the studies that have been done with medications, but the studies that are done in terms of verifying the validity or the usefulness of psychotherapy have exactly the same problems. So it's really hard to prove that psychotherapy works. I mean, there are studies now that are just beginning to come out on cognitive behavioral therapy, on interpersonal therapy, but one can criticize the control process at least as vigorously as one criticizes the control process that's used in pharmaceutical studies. So, and for years, for decades, psychoanalysis, for example, which was the gold standard for treating whatever, had zero, and still has zero validation in terms of any kind of scientific controlled study. And yet people say, well, it's got to be good because you talk to somebody and you make them feel better and stuff like that. But in terms of knowing that it does benefit, at least in terms of a year from now or 2 years from now, we're as ignorant about that as we are about, and more ignorant about that than we are about medication. So just be aware of that as well.
I don't want you to go away with the thinking that nothing in medicine is provable or demonstrable. And the contrast that I always like to make with psychiatry and mental health in particular is antibiotics, which have also come up a couple of times. So, I mean, in the case of, let's say, pneumonia, you know, there's all sorts of physical signs that tell a doctor with a fair degree of accuracy that this person's got pneumonia. There's the symptoms that the person reports. There's the signs that the doctor can, you know, hear when they listen to the person breathing. And then you get a chest x-ray, and there it is. You've got this big gray splotch in the middle of your lungs that's the pneumonia. You can give someone an antibiotic, and you can retest. You can do that x-ray again and see that it's gone. You can listen to their lungs again and hear that the sounds are gone. I mean, those are really hard objective criteria. And the point I do want you to realize is there is nothing like that in psychiatry. So while I agree that there are other areas of medicine that are gray, it's really important to understand that all of psychiatry it's the most subjective area of medicine, and it's therefore, in my opinion, the most vulnerable to exploitation. And it's very important as informed consumers to be aware of that.
I think that's an excellent place at which to stop and to open up the discussion to